Good afternoon, everyone. Thank you all for being here this morning. I'm Joyce McConnell, the Dean at West Virginia University College of Law, and I welcome all of you to the John W. Fisher Lecture in Law and Medicine at the West Virginia University College of Law. This lecture series always makes me happy, and I want to tell you why. Because I love interdisciplinary work, and I think it's very, very important in this time that we work together between law and medicine to make health care accessible, to make people live longer and higher quality lives. And I think the combination, the marriage of law with medicine is what can make this happen. So it's with great delight that I can say that the lecture series today was made possible through the generosity and the vision of Dr. Thomas S. Clark, his wife Jean Clark, and their two sons, Chad and Stuart. It was established in 1998. The Law and Medicine Lecture is one of 10 that they created across the university in various disciplines, always with a focus of bringing disciplines together to solve what seems sometimes to be insoluble problems. This one honors their friend, John W. Fisher. It was in his honor when he became the 15th Dean of the College of Law. The Clarks are very loyal mountaineers, as you can see. Dr. Clark earned his medical degree at WVU in 1975 and became the medical director of Mylan Pharmaceuticals and the former CEO and owner of Clinical Pharmacologic Research Incorporated. His wife, Jean Clark, completed her BA at WVU in 1967 and a master's in education in 1974. She served the University Foundation on its board of directors. Together and with their sons, they decided that they wanted to continue their commitment to WVU through this wonderful lecture series, but also to honor John Fisher, who was the first William J. Mayer Jr. Dean and who now is the William J. Mayer Dean Emeritus. And John is here with us today. Thank you, John, for being here. Those of you who know Dean Fisher know that the West Virginia Supreme Court of Appeals refers to him as the state's foremost authority in the field of property. I just shorten that and I call him West Virginia's property guru. If you want to know something about property, you call John. On behalf of the College of Law community, our thanks go out to the Clarks for their generosity and for their recognition of the important and beneficial connections between law and medicine. Thank you again for being here with us.
Good afternoon, everyone. I am Ann LaFaso, the Associate Dean for Faculty Research and Development here at WVU Law, and thank you so much for coming here today. It is with great pleasure that I introduce to you today Sara Rosenbaum, the Harold and Jane Hirsch Professor of Health Law and Policy and founding chair of the Department of Health Policy at George Washington University School of Public Health and Health Services. In addition to being all of that, she also holds professorships in the schools of law and medicine and health sciences. How's that for achievement? Professor Rosenbaum has devoted her career to issues of health justice for populations who are medically underserved as a result of race, poverty, disability, or cultural exclusion. An honored teacher and scholar, a highly popular speaker, and a widely read writer on many aspects of health law and policy, Professor Rosenbaum has emphasized public engagement as a core element of her professional life, providing public service to 6 presidential administrations and 16 Congresses. She is best known for her work on the expansion of Medicaid, the expansion of community health centers, patients' rights in managed care, civil rights in health care, and national health reform. Professor Rosenbaum worked for President Clinton, directing the drafting of the Health Security Act and designing the Vaccines for Children program. which offers near universal coverage of vaccines for low-income and medically underserved children. She regularly advises state governments on health policy matters and has served as a testifying expert in legal actions involving the rights of children under Medicaid. Professor Rosenbaum is the leading author of a landmark textbook that provides an in-depth exploration of the interaction of American law and the United States healthcare system. She has received national awards for her work, serves in government advisory committees, private organizational and foundation boards, and is a past chair of Academy Health. She is a member of numerous other advisory committees, including some that advise Congress on federal Medicaid policy. On a personal note, I had the pleasure of dining with Professor Rosenbaum last night with a few of my colleagues. In addition to being an accomplished public servant, healthcare advocate, teacher, and speaker, she's a proud mother and wife. I enjoyed hearing about her daughter, an accomplished theater director, and her wonderful family in Alexandria, Virginia. The conversation was lively and interesting. If this afternoon is anything like last night, you are in for a treat. On that note, please help me welcome Sara Rosenbaum.
I strongly recommend the Andalusian steak. Yes? That's what we ate. It was delicious. I'm so delighted to be here today, and I thank you for inviting me, and Dean McConnell and Dean LaFaso. Thank you so much for just the warmth you have shown, and one cannot help but feel the great pride you both have in the school, the university, the state. It's really a pleasure to be with you all today. My plan is to try and keep my formal remarks to about 25 minutes or so, because I am talking about something that is sort of alive and happening around us at this very moment. They're trying to build the data hubs even as we speak, which of course is the implementation of the Affordable Care Act, and I'm going to leave plenty of time before we finish this session for questions and interaction. My talk, as the published materials say, focuses on the relationship between health reform and medically underserved populations. And really, because it's a talk to a group of people who have trained in law predominantly, it's designed to focus on how an incredibly complex law has attempted to reorganize the environment, the health environment in which we live, to try and change the relationship between people and health care, between society and the health system society has built, between industry and society, through a series of changes of the kind that law tends to use, the various levers that are open to the law. What the principal design of the law is, and the issues that I think you really have to pay very close attention to here in West Virginia as the law unfolds. I want to begin by talking about the critical nature of this topic for West Virginia. This is a storied state. In my career, I have done some work in West Virginia. A lot of my early years as a lawyer were spent, before I went to university, working with community organizations to develop community health centers in both urban and rural parts of the country. And, of course, West Virginia has quite a long and honored history of developing community-based health care services, particularly in rural areas of the state, to try and reduce disparities in access to health care and, of course, to interventions that improve health. And so I became familiar early in my career with the profile of West Virginia, and yesterday, as I was getting ready to come here, I spent some time looking back at statistics about West Virginia, and of course the figures are, I must say, in many ways show the amount of work and the amount of gains that have been made over a long period of time here. but they also underscore the amount of work that lies ahead. You have today about 260,000 uninsured people. Your uninsured population is about at the national average, actually slightly lower, because, in fact, the state has made quite a commitment to the Medicaid program. We'll get into that. It's not because you have a booming employment-based health insurance system. It's because the state has made public health interventions. You still have about 110,000 state residents who live in areas that have been designated as medically underserved by the federal government, typically because they show a combination, sort of one of the great lethal combinations of elevated health risks coupled with a shortage of primary care. You need something like 50 primary care physicians moving into practice in urban and rural medically underserved areas to close at just the primary care gap. And so your predicament reflects that of many other states. Your statistics, of course, I'm sure you are familiar with some of these, show the kinds of population health challenges that are emblematic of the United States but tend to be particularly serious here. I was quite struck by the disparities in cancer rates here. Of course, an obesity disparity that is the hallmark of much of the sort of the southern, southeastern tier of the country, and of course tremendously elevated levels of smoking, which typically underlies a lot of these other trends or is associated with these trends. So you have major public health challenges, major population health challenges, and at the same time, even with so many people being low income here, medically underserved, uninsured, you have a real issue in West Virginia. I was shocked, we talked about it last night at dinner, with health care spending. Your per capita health care spending is very high. The United States, as you probably know, ranks, it doesn't do us justice to say we rank at the top of the world in health care spending. We are in another galaxy entirely. Here in West Virginia, your numbers, your per capita spending numbers are actually significantly higher than the U.S. national average for reasons that were not completely and immediately clear to me, but I raise it because it comes back around to some of the issues that the Affordable Care Act is going to make us confront in the coming decades. So with that as a backdrop, I want to turn to the Act itself. It is, needless to say, for those of you who have brushed up against it in any way, shape, or form at this point, an enormously complicated law. It's about 2,200 pages in length. You always see those political ads where they show you all the page numbers. So it's about 2,200 pages in length. And the reason it's so long, of course, if you know anything about law at this point in your career, either you're a member of the faculty or you're a practicing lawyer or you're a student, so you'll be at various stages of understanding this. It is much more complicated to write a law, write an act that amends numerous underlying laws than it is to write an act that displaces law. So when I was working for President Clinton, the First Lady at that point, who of course headed the task force, wanted me to get for her the Canadian National Health Insurance Law. The Canadian law establishing their Medicare system runs 8 pages, and that includes 4 pages of French translation. I'm sure that is, this was 93, so it's probably a few more pages in length, but I mean they just basically cut a law out of whole cloth, established a devolutionary system for the provinces, and have worked under that law ever since. In the United States, of course, because our healthcare system is so complex, our legal and regulatory mechanisms for engaging with the healthcare systems are every bit as complex, and a lot of that complexity is the creation of the system itself. If you learn nothing else as a lawyer, you know that regulated industries tend to write very complicated laws because the laws are essentially designed to maximize deference to the industry itself, and often in writing legislation that maximizes deference to the industry, you have to write dozens and dozens of pages of law. So the law is about 2,200 pages, and it overlays all of the preceding health care laws, so the Social Security Act, the Public Health Service Act, labor laws, tax laws, every major body of U.S. law that intersects with the health care system for all practical purposes is addressed in the Affordable Care Act. As a result, it's very long. But if you scrape away the length and you get down to essentially what fundamentally the Act is designed to do, it's designed to advance the health of the population. And it does so through three levers that really ought to be familiar to any student of the law. The first, of course, is regulatory levers, and we'll talk about that. The second is redistributional levers, and we'll talk about that. And the third are what you might think of as the collection of legal tools in the toolbox known as incentives. So how do you use the law to create various kinds of incentives, to codify formally those kinds of incentives that are informally used all the time by all of us. You know, if you don't go to bed now, there's no dessert. Or if you don't go to bed now, you won't have, well, we're not going to take you to the zoo tomorrow. So a downside risk and then an upside risk. Oh, if you go to bed now, you get to go to the zoo tomorrow. So sort of upside and downside risks, but codified. So those are the three major legal levers familiar to all of us. And yet this very complicated law with these various legal levers sort of working away inside the law is meant to work together as a whole. And you can lose sight of that given the drama that has surrounded this law, the amount of opposition to the law, which, to be honest, it was real bad. If you were living in Washington, D.C. through this, you just couldn't believe anything could get any worse than this. But if you look back at the history of Medicare, Medicare went through ferocious opposition. It lasted shorter. It was all done in a few months. This thing dragged on, as you know, for a good year plus, followed by, of course, 2 years of incredibly ferocious and landmark litigation, and now we are just into, and then, of course, the presidential election, and now we are into the politics of nullification. And so if you add all of that up together, you get this unending schlag in terms of creating the law and implementing the law. And it prevents you from seeing the law as a whole. But it's important to understand that the law actually has a resonance as a public health intervention and hangs together reasonably well. Whether all of these pieces are going to work easily, the mechanics of the law is a different problem. But the vision of the law to sort of take what we've got and make it work better is an enduring one. And you can ask whether the law is, in fact, a stopping point or, in fact, a way station, whether it's designed to take us sort of on a journey that we've got to go through to get to something more rational, or an end in and of itself is not clear. I always tell my students that my favorite parable, if you're a lawyer, I think one of the best parables ever is, of course, the story of Moses, who was given a choice by God. He was given either the shortcut to bringing the slaves into the promised land of 40 days, or he was given the 40-year route. And he took the 40-year route because he realized that it was going to take that long for his society to evolve to a place where they could come out living in sort of a different social construct. And this is not dissimilar. You know, we are on this long path to improve what we've got. Maybe it will improve, maybe it won't, maybe we'll be ready for something that's more consistent with the kinds of social contract laws that you see in other wealthy nations. But this is what we're working with. So let's get down to its major elements. The regulatory element is probably the one that's best known to everybody because this is the famous shared responsibility provision that was litigated at the court, the requirement that individuals, in fact, if they can afford to do so, buy insurance or acquire insurance, in the case of poor people, through the Medicaid program. We now know that because it was structured as a tax benefit, it's actually a big incentive, right? It's really not regulatory in the regulatory commerce frame, although the minority of the court said yes, it is, and it's quite constitutional that way. But it's one of those incentives that hinges on regulatory. So I've grouped it for purposes of today under regulatory. But beyond the sort of quasi-regulatory provision is the part of the law that really is regulatory, about which there is no constitutional doubt at all, which is the remaking of the insurance industry in the United States. And that is ground zero for the law, and the insurance industry is remade in several ways, and it's remade in some cases for all of us who have benefits, including those of us who are enrolled in very big self-insured plans like the one at the university. But the primary focus is on the small group and individual market. If you look at West Virginia statistics, you can see that you have no individual market to speak of, and your small group market is very shaky and very costly. And so the regulatory interventions are an attempt to make coverage more stable and more accessible. The big interventions that you probably know about are, of course, the ban on pre-existing condition exclusions, and what insurance lawyers call guaranteed issue and guaranteed renewal, and related provisions, a bar against discrimination against certain populations based on their health status, and other changes all designed to make insurance open, to essentially force insurers to look at communities as a whole, to stop looking at them as markets to be cherry-picked, and to force them to look geographically at communities. There are some limitations to this regulation, the biggest one being what's called modified community rating, so that there can be differences based on age, based on family size, based on geographic location because of the difference in health care costs, and based on use of tobacco, which we'll come back to. But by and large, the premiums charged are to be equal based on community. And that is it's so profound given the history of health insurance in the United States that it's hard to overstate what the remaking of the insurance industry means. The Act also redefines what it means to be covered in the individual and small group markets. It does so through what's called its essential health benefits amendments. They are pretty modest. There's been a lot of complaints against the administration over its weakening of what should have been a stronger and more detailed standardized benefit design for individual and small group products. Again, even as someone who has complained loudly about some of the choices that have been made, I would say that it's such a profound step to introduce standardization of any kind into the commercial insurance market that the movement toward a standardized meaning of coverage, both in benefit design, what's covered, the cost-sharing rules, is quite notable. And, of course, the most famous of these benefit design modifications has to do with preventive benefits. A lot more preventive benefits coverage, and, of course, this is where the very controversial contraceptive coverage provisions sit. There's also a lot more financial accountability in the market than there was. Important medical loss ratio formulas have been established to basically make sure that when insurers take a premium dollar, the vast majority of it is spent on health care and not on management costs or administration fees or profit margins. And the notion of some transparency in pricing. So a rate review system that goes into effect in all states. So those are some of the big regulatory levers. The other big regulatory lever, again, you could put this under incentives if you wanted to, is the establishment of exchanges, which we will come back to. West Virginia is what's known as a state partnership exchange. The federal government is going to come in and build the exchange infrastructure, and then the state is going to partner with the federal government around certain aspects of the exchange. And the exchange is basically an online purchasing system for people in the individual and small group markets. And it's a combination of sort of open access to certified products, but a regulatory atmosphere, so that products, in order to be sold inside the exchange, have to meet certain regulatory standards. Let's talk for just a minute about the redistributive provisions of the Act. These are the ones, of course, that create the affordability. You cannot mandate that Americans buy insurance if it's not affordable. And so there are two principal mechanisms that were used to create affordability. One was the Medicaid expansion, which, of course, was the portion of the law that was struck down as unconstitutional and then saved from extinction. You know, once a law is declared unconstitutional, the law is a nullity, it goes away. The court, which I think is not as well understood as it should be, both struck down the provision but then saved it from oblivion by essentially establishing that the remedy in this case was not to eliminate the expansion entirely, but to allow states to refuse to comply with what otherwise would be a mandatory requirement of participation in Medicaid. That had the important effect of leaving the money on the table, because had they simply said the expansion is unconstitutional, all the $500 billion of funding to cover the poorest Americans would have gone away. So the money is on the table, but as you know from what's happening here in your state, there are many states that are in the throes now of debating what to do about the Medicaid expansion. The premium subsidies, of course, are designed for people who make too much for Medicaid and too little to be able to afford their coverage. These are people without access to affordable employer-sponsored benefits, and they are people with incomes generally between about 100 and 400% of the federal poverty level. The Medicaid coverage actually goes up slightly over the 100% mark, and I'm going to come back to this issue because one of the most important things you're going to have to pay attention to is the alignment of the Medicaid subsidized market and the exchange subsidized market. This is ground zero for making this law work in West Virginia and every place else. And it's going to take a tremendous amount of collaboration between your state agencies to make this happen. The incentives in the bill are enormous. And there are all kinds of incentives in this law. There are incentives to change the way health care is delivered. So we see the advent of what's called the Medicare Shared Savings Program, which encourages clinical and financial integration and waives various transactional laws that would otherwise bar this kind of collusion, really, by altering antitrust and fraud principles to allow the creation of horizontal collectives of providers who otherwise would be competitors to work together in unity to create a shared ownership and clinical integration with the potential for shared savings. The best evidence on health care and from healthcare research suggests that you get much better quality care and more efficiencies if you have large-scale collaborations. It's going to be a big issue in a rural, highly decentralized state. Medicaid, we see similar tools which the states are using to various degrees to sort of try and nudge the health delivery system toward greater clinical and financial integration, particularly around people with serious and chronic conditions, who tend to be, of course, the most costly people in any healthcare system, and who have gotten historically very poor quality care. So it's, like the old Marx Brothers joke, in this case, though, such bad food and so much of it. So much care going on of questionable value. payment reforms designed to get more efficiencies going by getting the American healthcare system to think more about sort of delivering episodes of care. These are all reforms, by the way, that are borrowed from abroad. I mean, we did not think these things up. This is what European nations have been doing now for some time. Switzerland, Netherlands, Germany, France, England, everybody's sort of moving toward this more holistic approach to buying health care to force some efficiencies that otherwise don't exist. We also see some very important and less well understood incentives. One being community benefit. So nonprofit hospitals are obligated as a condition of their tax-exempt status to provide community benefit. And community benefit is a vaguely understood concept. If you look at how hospitals have spent their community benefit investment, the investments generally have gone back into improving the hospital. So absorbing losses from public insurance, investing in research, investing in training. What the Affordable Care Act does is, and I put this one under incentives, probably a hospital lawyer wouldn't think this way, be regulatory, but essentially builds up the conditions of tax-exempt status to require a far more outward-looking mechanism for making community benefit investments through a process known as the Community Health Needs Assessment and an implementation strategy process, which becomes extremely important. We'll come back to this as sort of a mechanism for trying to figure out where the resources are in the state to go through transformation. A couple of other incentives that I'll just throw out. I don't think we'll have time to spend, we probably won't be able to spend time on them, but one is community transformation grants through the Prevention Health Trust Fund. These are grants that are going out to states and localities to engage in activities that aren't health care in nature. They are health improvement in nature. And these are funded all over the country. I don't know actually if West Virginia has received a transformation grant. But there was some synergy between transformation grant activities and what a hospital might invest in the form of community benefit. And finally, in an activity that I'm sure is going on here, Congress established the Community Health Center Growth Fund in order to be able to enable community health centers to increase their capacity in advance of full implementation of reform, which is expected to of course, affect the use of health care. So what are the issues that you've really got to be watching here? I mean, there's all this stuff, and then the question is, you know, from a public health point of view, where should the focus be? The first one is the Medicaid expansion, and I gather that no final decision has been reached here in West Virginia. The governor is still studying the issue. The legislature is studying the issue. The best evidence at this point from the best research that has been done suggests a couple of extraordinary aspects to the Medicaid expansion. The first is, of course, the sheer amount of federal financing that it brings into the state. And there's a very interesting study by the Urban Institute that shows that even if West Virginia, like any other state, didn't enact the expansion, that its 10-year spending under Medicaid would be about the same as if it were to enact the expansion because, of course, so much of the expansion is wholly federally funded. And so the irony is that this is the way that the state has of insuring hundreds of thousands of people, and the outlays, if you project where the state's Medicaid program would be with or without the expansion, there's almost no difference, a couple of percentage points different. The other is that in any state with a lot of small, low-wage employers, a lot of the folks who work, maybe for auto mechanic shops, dry cleaners, you know, the sandwich shops we passed today, the wages are so low that the bulk of these folks are going to be Medicaid eligible, not exchange eligible. Medicaid eligibility is up to 138% of poverty. That's adjusted income. So your income probably would be in about the 160% of poverty range, gross income, and you would be covered through Medicaid. That's the way the law works. And the great group that has helped are minimum wage earners and their families. And in research I've done with a colleague at Harvard, what we have been able to show is that the great bolus of young, healthy workers out there who will benefit from the Act are going to come in through Medicaid. So it's not only a great boon to the state's economy, it's a great boon to really the backbone small employer, small low-wage employer climate that sort of characterizes the West Virginia economy, I'm sure. So that's a huge issue. You also face, if you don't do Medicaid, the spectacle of having national health reform in West Virginia with only the state's poorest citizens left out. Because, of course, if you're a legal resident in West Virginia, you are eligible to go in through the exchange. And you don't go through Medicaid then, ironically, for reasons related to Medicaid. So the only people who will be left out are West Virginia impoverished citizens. And other people will have coverage. And, of course, it will make the disparities even greater than they already are. The second big thing to watch is the federal exchange. So you have opted, the state has opted for what's called a federal exchange with a state partnership, which means, and it's a very sensible thing to do, I've said to many friends, if I were a governor, I would have made this choice absolutely, especially in a smaller state, poorer state. Let the federal government come in and build the mechanics for you, okay? Get the website going, get the enrollment system set up, all of the mechanics. Very similar, for those of you who are familiar with Medicare Part D, the federal government has already built an exchange once. So this is the same thing. You're going to build an online shopping center, fine. You guys come build the online shopping center. We'll give it a West Virginia face. And you worry about the mechanics. So there are two sides to the state partnership. One is what I would call the supply side. That is, the states partnering with the federal government to regulate the marketplace, to decide who's going to be the qualified health plans that get to come in and sell inside the marketplace and what the terms of the sale are going to be. The state's going to make the decisions about, for example, how hard to bargain over rates, very important for the seller industry, and generally regulate. It's in that sense, it's an extension of the regulation of insurance, which is a quintessentially state operation. So that's one side. The other side is the demand side. It is creating, it is making sure that this marketplace is open, that the small employers who get premium tax credits and good coverage and some administrative support that they don't have outside the exchange market can come and use it for their groups, and more importantly in some ways that individuals, the tens of thousands of individuals in West Virginia who are entitled now to subsidized coverage are able to enroll. And there, interestingly, the governor has indicated in his letter to Secretary Sebelius that he is much less interested in the state playing an aggressive role. The governor is saying we are focusing our time in the partnership arrangement on the supply side, but we have no intention of spending a lot of time thinking about the demand side. So about easing the barriers to enrollment. They expect that the federal government will carry the weight here, and the federal government will do things. They will do navigator contracts, as they're known, and enrollment assistance partnerships. But it is a tremendously important thing how the state itself embraces the notion that hundreds of thousands of people in the state should be eligible for coverage. And the effort that the state makes through the various levers that only the state knows, everything from community organizations to its health centers to its health departments to, in some states they're talking about, but Massachusetts used the Red Sox for this. So, if the Mountaineers were all telling people in a million public service ads to go out and get insurance, really appeals to young working adults with their families who are potentially eligible for this or Medicaid. And it's also going to be incredibly important to the success of this how well the state Medicaid agency and its CHIP agency, the Children's Health Insurance Program agency, play ball with the exchange. How much do they align themselves? Because one of the biggest risks in this whole model, turns out, lies with people whose incomes fluctuate, which is the way of life for lower wage folks. I mean, we all have fluctuations in income, but what you discover among low income earners is that the fluctuations are very great. And don't forget, what we have here are bright lines between markets. So what we have found in our research is that over the course of a year, 50% of the population will experience 2 or more shifts back and forth between these markets. It's called churn. It has a name, market churn. You churn young families enough time across these 2 markets. You tell them you've got to go back in, redo your paperwork, leave the plan you were with, pick a new plan, pick a new provider, different markets. They don't talk to each other. You do this to people enough times, and they walk. And they are, even though they are under an obligation to get affordable coverage, they're probably pretty much penalty-proof because their income is so low. The only thing they will lose, horribly for them, of course, is part of their earned income tax credit, which you really don't want to see happen. That's, money that's crucial to live on. So getting the state agencies to communicate with the exchange on both enrollment and then on the creation of the market, creating plans that are multi-market participants with multi-market provider networks so that people can pick a plan, pick a doctor, stay with their plan, and essentially have, the bank of Medicaid and the bank of premium subsidies talking to each other to align up the financial subsidy is absolutely crucial here. I think, quite honestly, because the state has decided that its formal role on the demand side is going to be relatively limited, this is a place where it's going to be the providers, it's going to be community organizations, it's going to be the informal social networks of the state that embrace the law and make it happen for the poor. And to that end, and I will close with this, this is where hospitals with community benefit obligations, I think, play an absolutely crucial role. The IRS has made it clear that investment in outreach, enrollment, navigation, anything designed to allow people to essentially connect to health insurance is considered a community benefit obligation under the law. And so I close by just noting that where all of West Virginia's nonprofit hospitals decided to embrace making outreach sort of a priority, this would not only be an act of kindness, it would be an act of great corporate compliance. So I will stop there. We have time for questions.
We have 10 minutes for questions.
Thank you for that talk. Medicaid expansion. One of the arguments against it is fiscal, and you've just shown how that's a very weak argument. Mm-hmm. Are there any other arguments against it besides the fiscal argument? And what is the response to those?
So the arguments that you hear most, I've spent the last 10 months of my life basically wandering from state to state, audience to audience, going through all this. The arguments that you hear most are that it's a broken program, it doesn't work, which is not true. In fact, the evidence shows exactly the opposite. There are a couple of very fine studies. One, the Kaiser Family Foundation collects and publishes online an enormous body of literature on Medicaid success in health care. The Medicaid and CHIP Payment and Access Commission, which I sit on, does the same thing, has documented extensively for Congress Medicaid's ability to make health care accessible to poor people. So you get a lot of arguments, and people say Medicaid's a broken system, and when you ask them what are you talking about, 2 issues come up. One is low participation rate, rates among private physicians, and the other is that people who have Medicaid have worse outcomes, and of course generally that's because they're in very poor health status relative to the general population. Low provider participation is a byproduct of two things. One is states' choices about how they pay providers, and the other is sort of the social engagement between medicine and the poor. So, and that predates Medicaid. That, you know, you go back to the origins of U.S. hospitals, and private physicians didn't engage with poor people then either. That's the reality. The other reality is, of course, that Medicaid is the financing mechanism we've got for the poor. There is no other financing mechanism. Small employers who pay low wages cannot offer employment-based coverage. They may be able to come into the exchange now and get a plan, but more likely they're going to, because it takes work to run a plan of your own, so they will just assume that their workers are going to go into the exchange and get coverage. If we don't essentially tackle the Medicaid issue and make the program work the way we want it to work, and states have a lot of flexibility to do that, there's no other financing mechanism. And I will tell you that Congress is not about to create another, because the reason that Medicaid was chosen, you know, people think, well, just a bunch of crazy people thought this up. There were two reasons. One is that it's 50% cheaper to cover people through Medicaid because provider payments are lower. So we've locked in the disparity. And the second is that, interestingly, I actually came forward with a proposal to replace the core of Medicaid coverage, the core that represents sort of the standardized coverage that everybody's supposed to get now, with coverage through the exchange, and then have Medicaid supplement for long-term care. And my proposal created a fair amount of interest and then was rejected because the insurance industry absolutely said no. They did not want people buying in the exchange market if they were poor. Now, interestingly, all of the research done subsequently shows that these are really healthy people. And one of the, by and large, a lot of the sickest people are already on Medicaid. And one of the reasons why some states are now coming around is because the administration has made clear that one option for a state is to actually take Medicaid and buy coverage through the exchange for poor workers and their families, which is sort of a way of bridging the two markets, and it goes back to, you know, this earlier suggestion. And so that may help break this logjam. But you know, the bottom line for a state like West Virginia is that it's tossing out a tremendous amount of revenue, both for the state and for its small employers. Yes.
I did want to maybe provide a short update on some of the things that you'd mentioned.
Sure.
I think over the last probably 2 weeks, our Office of the Insurance Commissioner did announce, I think they're going to hire about 150 community assisters.
Oh, that's great.
So they are going to kind of update that. But I was wondering if you could comment on what some of the other partnership states are kind of doing as far as consumer assistance, if you were aware of that. So.
Yeah, no, that's fabulous to hear. Generally speaking, the partnership states have been, you know, if you take the governor's letters and you read them through, the partnership states have been quite clear that they're going to deal with both supply and demand. They want to control both sides. They want it because the certification process is so integrated with the process of licensing insurers. A state's got to be there. And on the demand side, I think that states have come around to understanding that actually, particularly if your interest lies with a healthy insurance industry in the state, you've got to be on the demand side, because if you do not get thousands of young, healthy workers into your markets and you only end up with the equivalent of a high-risk pool, everybody is in deep trouble in the state. And so if, for nothing other than self-preservation purposes, most states have been very aggressive on both sides, and I know that the administration now is, you know, busy because of the problem of funding. They're busy scarfing up money from every place they can pull it, from the prevention fund, which has made public health people very unhappy, from the community health center growth fund, which has made the health centers not so happy. But everybody understands that if there's not hundreds of millions of dollars going out to the states to put people, into every place they can put them. Now, for example, every hospital and every community health center and, ideally every local health department should have online enrollment. Every place that's a use of care site. Schools obviously should be online enrollment sites with assisters there. And Syria, I was obviously being only half joking about the Mountaineers. My sense of this state is that if the Mountaineers really came out strongly across all the various Mountaineer teams for young adults coming into the system, I mean, this is an obvious place for the university to partner with the state, with the governor's office to push entry among the very people whose behavior, quite frankly, is going to determine whether we've got a viable insurance market or not. If I saw one more Mountaineer sign, I think I would, there were just so many signs, I thought, like the Red Sox.
Thank you very much. It was really interesting. This may be a naive question, but it seems to me that all these rather bureaucratic, structural changes don't really deal with the big problem, which is the enormous cost and profitability of the medical profession and everything associated with it, pharmaceuticals, medical supplies. And, for example, I always sort of laugh when you go now and do your copay, the so-called copay, which was what it cost to go to the doctor when I was a kid.
Exactly.
So all these things seem like, of course, no pre-existing conditions. That's great. Covering kids under 26 through family, that's great. Right. But the big problem seems to me, I had an MRI in Hungary. It cost $175. I had the same MRI here. It cost $3,600. So how do you deal with that problem, which is putting us in another planet?
So, you're obviously so utterly correct, and most people who are honest say that all this is going to do is it's like Peel, and that's what I'm saying. We don't know if the Act is a way station on the way to something else. What the Act forces us to do for the first time, because coverage is nearly universal, is confront the fact that if you don't do anything about the underlying cost of health care, you can blame insurers all you want, and I am not arguing that insurance is not profitable, but you've got the underlying issue. And there was a great article in Health Affairs, one of the leading health policy journals, that I was looking at on the plane ride out here about all these efforts in Switzerland and the Netherlands to try and use their exchanges to build a competitive marketplace to bring down their costs. And the article points, that's written by Swiss and German people, Swiss and Dutch people, that they've been totally unsuccessful. They don't know exactly. They're trying different things now. And by the way, they both, of course, as nations, regulate the price of medicine. So the reason that their prices are staying down, and they wanted their exchanges to bring the price down some more. But in both cases, their prices and the cost of care, the cost of care is half to two-thirds of what it is here. And so everybody's been experiencing, price high or cost hikes, but I do a lot of work in Israel and their public health system. The lesson over and over again is if you don't deal directly with price and technology, it's price and technology. And, we probably someday will come around to that, but I think you can't have that discussion with 50 million Americans hanging outside the system and with 1 in 3 of us at risk for being without coverage every 3 years, because people will tell you we got to charge these high prices because so much care is uncompensated. So, we'll get there, but not right away.
Good afternoon, Professor. Thanks for coming and speaking to us on this complicated issue. To go back to something you addressed earlier in your speech about providing more doctors, general practitioners, et cetera, for urban areas and rural areas, there's been a lot of discussion about per-service treatment costs to doctors under Medicaid and Medicare being reduced, and doctors wanting to drop out of those plans and take those patients. Can you address, if that's true, what the problem is with the doctors leaving, how severe that is, and B, how is the government going to incentivize those individual doctors to go back to these areas specifically and treat these patients if they're cutting the payments? How are we going to get them to go back there and reconcile that with keeping costs down?
There's no question that public insurance, including Medicare itself, is not as good a payer as commercial insurance. Medicare is actually looking at a total replacement. You can see that there's about to be a meeting of the minds between Democrats and Republicans in Washington about a longer-term fix for payment that includes some favoring of primary care coupled with incentive payments and a variety of other legal levers to replace this terribly broken piecework system that has to be fixed every year, sort of in peril of the program. You know, Medicaid's an issue for the state. I mean, the question is for a state realizing that it's expensive. Now, for 2 years, the Affordable Care Act does address Medicaid primary care payments. There's a bump up, which the state at the end of 2 years is going to either continue or not continue. And so that's an issue for the state. You know, what do we want to do to restructure provider payment in this state to try and get greater participation at the front end, which is generally considered to be a sign of a higher functioning healthcare system, to have a strong primary care system. The commercial insurance market historically has been much higher. I got news for doctors. That's going to last not a lot longer. What you are going to find is that pricing generally, I think, is going to come down. So to the extent that doctors have been able, particularly, doctors have been able to do what business people do, look for areas that are more affluent and settle there, where people either have good insurance or, you know, a lot of out-of-pocket payment potential or both. Medicine has just become much too costly for everybody. And so in some ways, this insurance reform is easy stuff. I mean, this is just a matter of bulking up some markets and putting some subsidies into place and, you know, creating exchanges and making them work. The transformation that's very tough, and it goes to the earlier question, that where we should have been for the past 25 years, but we haven't been able to be there because we don't have universal coverage, is how do we make medicine more efficient? How do we make sure that people earn good livings being clinicians, but that the system runs efficiently at the same time, and that the incentives are reasonable incentives? And we know the answer. The answer is larger group practice under somewhat more controlled circumstances with some of the worst incentives to maximize revenues in really bad ways removed. And this is where the Moses parable becomes in some ways the most important. A couple of years ago, I was out at a medical school doing a grand rounds, the most conservative medical school I've ever visited, ever. People were unbelievably opposed to the act. Wonderful medical students, hated the law. I spent a lot of time visiting with them, talking with them. And I just asked them, as it matters, this big rural program, you know, so what are you all doing? How many of you are going to hang up a shingle? Not a hand went up. In a generation, I mean, we will have, between the entrance of women into the profession, changing attitudes on the part of men about the relationship between life and work, and the impossibility of practicing alone. Nobody from this unbelievably liberty-driven medical school was going to go out and practice on his or her own. People will come into larger settings, and in another 20 years, medicine will look very different. It will be technology-enabled. People will be in big groups. There will be salary structures that, you know, that make sense. But this generation is just that we are living through the worst of the pain. and we've lost 2 generations. I mean, other countries are way ahead of us, so.
Thank you for coming. I, for one, appreciate the homework you did on West Virginia and the customized nature of your talk.